And now delving a bit more into the real world, we'll hear from Dr. David Alpers, who's actually joining us from the UK, and so he'll be joining us remotely. Some of you may know that Dr. Alpers brings to this workshop his extensive research background as well as his clinical experience to address the complexities of the practical application of personalized nutrition. Dr. Alpers.
Thanks very much for the introduction, and thanks for letting me participate at a distance. You've heard, can I have the next slide, please? We've heard we're in this meeting to try to figure out where nutrigenomics is. We've heard a lot of evidence that it's got tremendous promise. And we've heard evidence that also that behavior has a huge influence on what people do in terms of nutrition, and that behavior might possibly be modifiable. We also know that there are a great number of genetic tests that are available, most of them SNPs, but other defects have been found. But at the current time, most of those studies haven't been informative. The kind of the studies that have been outlined up to date in this meeting will lead you to think that with time we will have some good correlations, but right now they're not so much with us. So what I'm going to try to do today with you is to tell you why these studies in nutrition will be difficult, but not impossible, and why we're just at the early stages of where we can utilize this information. And the studies will be difficult because they require isolation of the effects of different individual genes and individual foods first, and then in combination, including having adequate control arms. And I don't need to remind you that when isolated effects are looked at or isolated nutrients are given, such as some of the antioxidants, vitamin A and those sorts of things, the results haven't been very impressive. And there are a lot of reasons for that, but the fact is that these studies are complicated. And the studies are also complicated because it's very difficult to prove causation from associations by any means. I'm just going to go through with you some of the Hill criteria to show you why this is increasingly so in nutrition. Next slide, please. So here's some of this Hill criteria. These are not absolute criteria, of course, but they give you a rough scaling of how you can deal with associations. So if there's a strong association, that helps you, but that's often not what's present with many of these associations that have been found, either with genetic changes or with metabolic changes. The association needs to be constant, but at the present time, with many of these associations in nutrition, there's only a few studies, so it's hard to talk about the constancy of the association. You really like to see that there's one cause, one effect, but because there's so many components to the diet, because they interact so much, because they cause so many metabolic and new changes in the body, it's very difficult to come down to one cause, one effect. We're not talking here about inherited diseases with a single genetic change, as the previous speaker spoke about, and even there you can see how complicated it is. But here we're talking about the usual target for nutrigenomics, which is to try to prevent disease in relatively healthy people. Then there should be a dose-response relationship, and although there is in genetic studies when you knock out one of the alleles or you have a quarter or a half of the gene functioning, that's usually not available for the spontaneous SNPs that are found in the various association studies. There's always a scientific justification for these associations, and some of them are quite convincing, but there are many of them based on in vitro and animal data, and rather few of them based on clinical data. You like to see coherence with other data, but other data related to these associations are often quite limited in nutrition. And you want to see intervention studies in randomized controlled trials. But these are very difficult to perform for many of the reasons that we've already outlined, and they're not, many of them are not done with interventions. Now, there's another problem that makes studies in nutrition difficult, and that is that except for the genetic abnormalities where a single gene defect causes a disease, it's very difficult to isolate which effects of the phenotype are related to nutrition and which to other factors. Can I have the next slide, please? So there have been consensus criteria that have been developed by a number of organizations for what malnutrition is. And I'm going to speak here of malnutrition, but these conclusions are going to be just as applicable to the prevention of disease as I'll outline for you. But the consensus criteria have been more or less agreed on how you tell someone is malnourished. But then in clinical practice, there's two major types that we all see. One is where you have pure starvation. And in pure starvation, if you refeed, if you give nutrients back, you reverse the phenotype. In chronic diseases, there's frequently superimposed mild or moderate inflammation and or other factors. And some of the diseases that would come to mind are obesity, or rheumatoid arthritis, inflammatory bowel disease, cancer, those kinds of diseases. And in that situation, you really don't have any idea clinically how much replacing nutrition will make to the phenotype. And in fact, clinically, usually by the time we see a well-developed chronic disease, the effects of the disease itself are more potent than that of nutritional deficiencies, although there are certainly differences in individuals. And then, of course, as again, Dr. Morris just talked about, you can have an acute disease with trauma and burns and things like that. And inflammation is an important component of those disorders as well. Now, the disorders in which genomic links have been sought include many of these same kind of conditions: obesity, cancer, diabetes type 2, aging, even pregnancy. And so to separate out what the effect of nutrition is becomes difficult. Most of these conditions have a component of inflammation, and the only conditions without inflammation will respond in a clear manner to nutrient supplementation. So this right away makes studies linking genomics, where you don't yet have a link to a clear clinical phenotype, it's going to make it difficult, because the change in whatever phenotype you decide to study then may be related to nutritional supplementation only by chance or only in part, and we need a lot more information to know that the phenotype that we're going to study will be affected by the intervention. Next slide, please. So what approaches have been used to try to link genetic effects or effects in the genome to nutritional phenotypes? Well, there's a huge amount of work on in vitro studies and in vivo animal studies to support the rationale. And cancer is a good example here. There's many examples where you can show that things like curcumin and turmeric and garlic extracts and other nutrient components have potent roles in preventing some changes in cells or in animals, but they haven't translated to human data yet. And human data, when present, is often less suggestive than the animal data. We see this with studies of caffeine metabolism, with omega-3 fatty acid supplementation, and in particular, we see them with attempts to supplement with antioxidants. The antioxidant pathway has been well worked out in a variety of diseases, including cancer and a number of degenerative diseases. But the antioxidant theory of human disease, which was quite prevalent many years ago, has yet to be really proven by clinical studies. The mitochondrial story is a very powerful one, and I'm sure that sooner or later we'll get there. But at the present time, we don't have the data that we need. We also know that some genetic factors that can be detected aren't sensitive enough. So one example is HLA subtypes for celiac disease. We know that the two subtypes that are found in almost all patients with celiac disease are also very prevalent in the rest of the population that doesn't have celiac disease. So you need more sometimes than just the genetic change. We also know that there are other genetic factors that don't add much to the clinical information. So although we've known for decades now which genetic changes are determinant of lactose intolerance in humans, from a clinical point of view, we just find out whether people are taking milk products and take them off them for a short while, and that will tell us whether they're going to have a response or not. So we haven't needed that information yet to get personalized in that particular condition. Many chronic diseases are also related to the phenotype of malnutrition that I outlined before, and obesity is the major problem here. The problem with obesity and other nutritional disorders like that, including even to some extent diabetes, is that management with the standard of care nutritional advice is difficult by itself, and it's often not implemented. Now, the use of individual coaches, as was pointed out earlier, is a wonderful thing, and that's what trained dietitians do too. But we're going to have to get a lot further along the utilization of cell phones and things like that, and people's available time, both in terms of the patient and the coach, to get to the point where this really becomes a widespread phenomenon. So are we ready for nutrigenomics in 2017? I think we can expect that there's going to be a long lag before strong data are available, and it's going to happen one disease at a time. There's not going to be any great breakthrough, I think, that's going to say all of a sudden we can start using these things with nutrients with the expectation that general improvement will occur. And so I think we need definite effects on a clinical basis before we can really implement these things fully commercially. Next slide, please. So that's sort of the conclusion of where I would be now, but what can we do now, and what can we look forward to in the future? So right now, there are a lot of personalized internet services, and they come in a variety of different ways. You've heard about some of them already today. There are many of them. They're based on the analysis of a person's dietary pattern. The dietary pattern is often biased when it comes to the reporting that the patient does, but that can be changed with education, perhaps. We need to deal with the problem of a meal-based versus a food component-based bit of information, because those things are not exactly the same. Initially, people have been using mobile phone technology, and initially the uptake of these systems has been much greater with adolescents who have grown up with cell phones than it is with adults. But as time goes on and the population becomes much more accustomed to this kind of technology, I think this will improve. This will be a potent method, I think, for modifying behavior and potentially leading to changes in clinical outcome, but we don't have that potential change in clinical outcome yet. And the other thing that's important is that this will have to be with time. Because of expense, most of these experiments will be very short term, but what really counts with disease prevention and with nutrition in general is what happens over many years. And as everybody knows, the recidivism with weight loss diets is very high. And so it's very hard to keep up a change in behavior that hasn't been lifelong up to now. Nonetheless, this is a very potent method for going forward. It doesn't have anything to do with genomics yet, but if this behavior is changed in a meaningful way and we learn how to better change it, then it can be plugged into changes in genetic knowledge that comes about that's shown to be important in modifying disease phenotypes. Now, the second thing that can be done is you can have personalized nutrition based on phenotypic data. And that's been more difficult because it's more difficult to do a large study with a phenotype that means anything. I've given a few examples here. One is monitoring urine sodium and decreasing sodium-containing foods and having an effect on blood pressure. And that seems to work, although the effect is modest because, as you know, the effect of altering sodium intake is modest, but very definite. Another example that I give you is monitoring wristwatch accelerometer data to deliver physical activity, and that's part of a number of the wellness programs that are out there now, and that does work. But what we're missing there again is how persistent it is, how long people stay on it, and whether it will actually change a disease phenotype, either currently or in the future. And there have been a number of studies done with blood tests looking for metabolites. Not really yet too many studies with metabolomics, but those are coming. But this is development of a metabolic profile. There's one study that I give you here, which looked at the effect of vitamin D supplementation, looking at metabolites that should have changed with vitamin D supplementation, but they weren't found. Now, there are lots of problems with studies like this that we don't have time to go into now, but this is the kind of thing that will need to be done to look at phenotypic changes. We'll first start with laboratory phenotypic changes, and then hopefully that will expand to actual clinical phenotypes. Now then finally we get to personalized nutrition based on genomic data. And at the moment, what we mostly have is observational studies linking dietary patterns with various SNPs. And that's really not enough by itself. We know that you can change some metabolic changes if you, in certain groups. And the example I give you is of the folate acid metabolizing enzyme. SNPs in that enzyme have been shown to change homocysteine levels based on how much riboflavin you supplement in people with TT variants of that enzyme. But again, that hasn't yet been translated into a change in disease phenotype. Now, with all these three approaches that you can take, it's, as I've mentioned above, it's difficult to predict the extent and to which the potential users will want just a one-off result or will maintain a service long term. Certainly, some of the programs that are out there now are providing good incentives for people to stay. There's small numbers of patients right now, but that's what we need is a service that can be delivered long term, and that will eventually show that delivering that service leads to a change in disease progression or disease occurrence. Now, if it just makes people feel better, that's of course worthwhile too, but that's not really what we're talking about today. And just to leave you at the end to show you that there are going to be studies done, the Food for Me studies that are coming out of the European Union are developing data on consumer responses. And there's been one study published recently in the American Journal of Clinical Nutrition in which a study was done in which patients were told whether they had the variant in the FTO gene that was a risk carrier for obesity. And the patients who were told that they had that developed more weight loss in 6 months than the people who weren't. The differences were small, and they only went out for 6 months, but they might have been greater had they gone longer, or they might have been less great. What wasn't done, and I don't know how to do this really, is that the control group wasn't told anything. To be a real control group, they should be told something false. But that's, again, a study designed for a future date. The point is that studies like this can be done and will be done. So what I'd like to leave you with is the idea that the concept of genomics of personalized nutrition based on genomics is a sound one, and many of the strategies are in place. What's missing is the data that translate those strategies or the preclinical work to actual clinical outcomes. And I would leave you with the thought that that's going to be difficult, but it will occur. It will occur slowly, and you'll just have to be patient. Thanks very much.
Thank you, Dr. Alpers, and he will continue to be with us remotely and will participate in the discussion at the end of this.